Today, I'm joined by Amar, and we're going to be talking about nice guidance for glucose monitoring for type 1 diabetes. The emphasis there is, of course, going to be CGM and a little bit on hybrid closed-loop systems. I suppose, why is it so important, this glucose monitoring in type 1 diabetes? We do know traditional methods of monitoring, such as self-glucose monitoring, require frequent finger pricks tests, which is not only painful, but it gets in the way of people's lives. And we've known for a long period of time that the more frequently people test, the better they get in terms of control, which leads on really to CGM. Continuous glucose monitoring are these devices which stick on the skin and just pierce the skin to test interstitial glucose. So it's different from blood glucose. But what that gives, having a device there, often enabled with Bluetooth, can communicate to a reader or indeed just a smartphone and will be recording automatically throughout the day. So seeing those peaks and troughs, but also whenever the person is wanting to look at their glucose, they can look at it then and therefore act on that glucose. And it gives a lot more information than just the numbers. It gives trends if the arrow's going up or down, and you can share that data with healthcare professionals. And then, and of course, in terms of access to CGM in the UK, for type 1 diabetes, that's basically universal, at least in terms of access. They need to be supported. There needs to be an MDT around them who can support them. And of course, there's a variety of devices, and certainly I think it's important to involve patients. It certainly transformed the way I look at people's glucose monitoring.
Yeah, so I guess the NICE guidance, they changed. I mean, we've had continuous glucose monitoring for a good many years now, and it was always difficult to try and justify the usage of them without any solidified national guidance. So when the NICE guidelines in 2022 updated to include continuous glucose monitoring devices as a standard of care, basically, in type 1 diabetes for anyone who has type 1, that was quite an important step in the management of people with type 1 diabetes. So the NICE guidelines essentially said anyone with type 1 diabetes, if they would like it, would be issued a continuous glucose monitoring device. And this is either the real-time continuous glucose monitoring, where it's continuously sending data, or the intermittently scanned continuous glucose monitoring, where it's, as it says, intermittently scanned, or the Flash Libre device. Yeah. And so in type 1 diabetes, it was essentially anyone with type 1 diabetes could get that if they wanted it. So it's up to the individual, up to the empowering the patient to make the choices of what they would like. And majority of people would like that. I mean, I know if I need to check my blood sugars, I'd want that as well. But it's not for everyone. Some people just would prefer the finger pricks for whatever reasons.
Certainly from CGM use, I know now, I think in the UK, we're approaching about 90% uptake in terms of type 1 diabetes, which, given these devices have only really, I can clearly remember a time when we didn't have them. It's really just been the last 3, 4, 5 years.
I remember a time like that too.
Yeah, there you go. Even a young one like you. So certainly CGM has transformed type 1 diabetes, and I think we're probably more comfortable with that as healthcare professionals. We've seen them. In fact, lots of people see people who don't even have diabetes wearing them. That's probably for another day a conversation about that. But I think I think the hybrid closed loop. I want to know more about this.
Yeah. So I guess what these devices, CGM devices, allow is continuous monitoring of your blood sugars. But if you have diabetes, and type 1 diabetes specifically, you have to give yourself insulin. So traditionally, in the past, that would be okay. You check your blood sugars, and then you have to inject yourself with insulin. You have to calculate how much insulin you need and adjust it and dose it yourself, depending on what you're eating, exercise, etc., and your general basal requirements. But technology has developed, so now we had insulin pumps. Insulin pumps allowed you to be done regularly, continuously, with a standard amount of insulin, basal rates of insulin going in regularly, and you input extra amounts of insulin to give yourself with meals or etc. But that still requires input from the individual at all times. And again, at night, you'd have a standard rate that would be fixed, or kind of vary at certain times, but it would be very much a set amount of insulin that would go in at various times. What technology has allowed us to do now is to link up basically the pump and the device, and that's what a hybrid closed-loop system is, essentially. Sometimes called artificial pancreases.
Yeah, I've seen that term being used. Yeah.
Some people debate that because it's not truly a pancreas,
Sure.
is it? And it's just a singular hormone as well. It's only insulin that's being looked at. So essentially what they do is you've got the glucose monitoring device. It sends a signal to a transmitter or reader, and then an algorithm reads that blood sugar reading and then senses how much, and makes the calculations, the smart computer wizardry, to identify how much insulin needs to be given, and it tells the pump to give that amount of insulin in a regular kind of continuous loop.
So that means, for example, at meal times, people are not having to do all that calculation.
They still have to, actually. You're trying to catch me out there, aren't you? Yes. So whilst you might think, and what you think, okay, the Holy Grail is I can just attach it, don't need to do anything at all, I'll leave it alone, that'll talk to that, and that's it. That's not quite true, because again, if you still need to input how much you're eating, how many grams of carbohydrate, how many carbohydrate portions you are eating, so that it can then calculate the amount of insulin to give based on what you've inputted in. So you still need to be aware of that, what you're eating, and also if you're exercising as well, you need to change the rates as well, because and change the amounts of how your body will utilize the insulin as blood sugars and insulin as well. So again, there's a few things. You can't sit back and relax with this. It's still important to know you have to input and still have to be clued on to things, but it simplifies things a lot. You don't have to always think about it in the situations where you're not eating or doing something intensive. Overnight, for example, as well, most people are asleep at night, so you won't really be scanning or sensing or inputting anything in. But what the hybrid closed-loop system does is it's sensing automatically throughout the night, and it's adjusting and stabilizing your blood sugars overnight. So then you're waking up in the morning, you've got stable blood sugars, and most people have noticed quite a big difference with that as well, especially overnight.
So, certainly I can think of plenty of patients who it's quite a burden living with type 1 diabetes. So I can certainly think of a lot of people who may benefit from that. So in terms of the NICE guidance, what are they recommending? So
the NICE guidelines for the hybrid closed-loop system have come out, and they suggest essentially people with type 1 diabetes, if you're a child, adolescent, it's for you if you want it. If you're a pregnant woman, then again, it's ideal and standard in pregnancy to utilise a closed-loop system. So with children and adolescents and pregnant women, we've got that guidance. With adults, it's if your HbA1c is over 58 millimoles per mole, or 7.5%, and if you have significant disabling hypoglycemia and have been on a glucose monitoring device or on a pump, and you're still getting others hypos or that blood sugar is still high, then you should consider a hybrid closed-loop system for them. So it's quite simple, really. Children, adolescents, pregnant women, HbA1cs over 58 millimoles per mole or hypoglycemia, despite being on a pump or CGM.
So I know in CGM we've known that it not only improves quality of life but improves glycemic control, reduces hypoglycemia. Yes. So what are the advantages of a hybrid closed loop over a traditional CGM system? Is it similar?
That's an aspect. It will improve your quality of life. It will reduce your hypoglycemia and hyperglycemia at time in range, as you say. There's a lot. I think there's a lot more diabetes distress, mental health benefits really with closed-loop systems as well. What we're finding. There's still a lot more data needs to come in, but we've got some preliminary data with that. It's also allows for more, I guess, in pregnancy there's some good outcomes with hybrid closed-loop systems as well from major trials. Concept trial, I think, was one. So it's improving outcomes across a number of range, and even better HbA1c reduction as well, better tighter hypoglycemia, because if you look at CGM, it's still dependent on either someone in the pump or inputting things in, whereas with the hybrid closed-loop system, it's all encompassing mostly, and there's only certain things that need to be changed. It's a bit more reactive, and with newer therapies and quicker acting insulins and things like that, the lag time between what it senses and what it delivers what the effect on blood sugars is not as pronounced.
And so it sounds like the next wave of revolution in terms of technology in type 1 diabetes. So it's quite a challenge, because it's taken us several years to get to this stage with CGM. What's the plans really for rollout of hybrid closed loop? Because you've said a HbA1c of 58. That's a lot of people.
That is a lot of people, yes, and just under 1 million people with type 1 diabetes in the UK. So we've got a lot of people to potentially benefit from this. So what the NHS, what NHS England have done, is essentially create a rollout plan for the hybrid closed-loop system, and it's over a 5-year rolling period. So initially it's going to be children and adolescents in that period group first who are going to get the hybrid closed-loop system, and that's going to build onto the adults, as I mentioned before, and obviously pregnant women already can get it as well. So it's trying to reduce the variations in care, make sure everyone equitable access for all, which is never straightforward, but it's about getting everyone aware of it and everyone working towards all the diabetes teams across the country, offering it to their patients at the right time and as recommended. But there will be some delays. Not everyone will get it straight away, and that might frustrate a lot of people. But again, we're in a finite system.
Sounds like the old Birkenhead Convention, which is women and children first. But anyway, and we can go on. I can give you a whole story about where the Birkenhead Convention comes from, but you probably don't want to hear that today. But it's a fascinating tale. Anyway, so thank you, Amar. It really is the next wave in technology in terms of hybrid closed loops. I think we're fortunate living in the United Kingdom at this time and serving
one of the first health
patients
systems in the world to do this.
Absolutely. So we've had amazing leadership in the UK on this, and it's great to see it actually going out and changing lives. And it's going to take some time, I think, as you say. There's going to be patience, and also I think if you're a primary care physician and wondering why all these secondary care endocrinologists and diabetes specialist nurses are complaining about workload, this is why. There's a lot of people who are having to go through this hybrid closed loop system, and that's taking a lot of time. So as you said, we've got other topics to cover, so please check those out. In particular, we're going to be looking at the Type 2 guidance when it comes to access to CGM and beyond. Thank you for your attention. Bye-bye.